Our first keynote speaker is Dr. Dana Thompson. Dr. Thompson is the Lauren D. Holinger Professor of Pediatric Otolaryngology at the Ann and Robert H. Lurie Children's Hospital of Chicago and Northwestern University Feinberg School of Medicine. She received undergraduate and medical degrees in the 6-year BA/MD program at the University of Missouri, Kansas City, here where I currently am speaking from. She completed a master's degree in clinical outcomes research at the Mayo Clinic Graduate School of Medicine and MBA from National Louis University in Chicago. She is uniquely fellowship trained in both laryngology and pediatric otolaryngology, including a faculty position, residency, and laryngology dysphagia clinic outcomes research fellowship. She spent 18 years of her career at the Mayo Clinic and was the founding chair of the Division of Pediatric Otolaryngology in 2011. She achieved the academic rank of professor, making her the first African-American woman professor in the specialty of otolaryngology, head and neck surgery in the United States. Today, she's about to speak on inspiring change from within. What can we do to address bias and health inequity in the era of value-based medicine? Welcome, Dana.
Good morning, Brian. Thank you kindly for this really very gracious beginning, I hope, of a relationship with this organization. It's really an honor to be part of this today. I'd like to also a public thank you to Dr. Ellen Friedman, who is also on your board. Ellen has been a mentor, sponsor, friend of mine for nearly 25 years and has also connected me to you today. An additional ask from everybody participating today is I do have a live audience polling response system and would really encourage everybody to participate. We'll have 4 questions embedded through the presentation here. The instructions are that you can text 22333 and Dana Thompson 743, or you can enter by the poll.com/Dana Thompson 743. And I've also placed the texting instructions in the chat box so that you will be able to refer there if you're not able to log on at this point. And then if someone could just confirm that you're able to see my slides, I'd be most appreciative.
Yes, we can see your slides, Dana.
Okay, thank you, Brian. So disclosures today, I have no financial disclosures. It's really an honor to be here. The perspective I'll bring today is that as a journey, as an underrepresented minority in medical education, I'm going to present part of my own personal story. Some of the information may be challenging to listen to, and I hope it's inspiring. And it's really a story. There is no intentional offense, and I just ask for the honor of listening, growing, and learning with me. My perspective is that I am a 3rd-generation African-American physician. As Brian introduced, I came from an unconventional 6-year BA/MD degree program in medical education, where starting at age 18, I was exposed to patient care and pretty much in an underserved population, which has also shaped my values and my vision in patient care moving forward. I have 29 years of postgraduate medical education and experience in a variety of different settings across the United States that are all disparately different. The Mayo Clinic, Cincinnati Children's, and the University of Cincinnati, and here at Northwestern. I have a significant respect and gratitude for this career experience and how it's shaped me and how I've grown. The other perspective I bring is there is a racial discordance between myself, most of the patients I care for, most of the people I work with, most of the students and trainees I teach, most of the people I mentor and sponsor and lead, most of my mentors and sponsors, and all of my bosses, except for my current boss, who's also a woman. I also come from the perspective as a surgeon administrator, leading an ambulatory practice in a diverse metropolitan city. The goals and objectives over the next hour is really how do we recognize how
I'm a
implicit and
third-generation
explicit
physician.
bias in the workspace and teamwork and patient care, to really learn approaches to manage a patient who would discriminate, and effective strategies for training,
This lady
faculty
is, I just
development,
entered that meeting
and education.
and she just talked about how she's a third generation.
Just a moment of pause. We're hearing a conversation. If you could kindly go to mute, that would be most appreciative. I'd also like to explore how bias adds to the risk of physician burnout and how to manage that. Acknowledge how our own biases contribute to healthcare disparities, inequity, and why change is essential in this day and age of the era of value-based medicine, and inspire and encourage self-reflection and acknowledgement of our own biases and how we can be part of the solution moving forward. So I think before inspiring within, let's describe within. We all belong within something. You know, we are part of a country, a nation, a community, a family. We all may have a spiritual or religious belief system. We're all within this profession of medicine and have a variety of different roles. We are in our own selves and our inner thoughts and our disposition, our character and our mindset. And in all of the frame in which we work, we have labels that we carry with ourselves, either our gender, our race, our generation, our sexual orientation. And this all shapes how we see the world moving forward. As you can see, we're all different. We all think differently. Our families of origin have shaped how we think, and we bring these perspectives into the workspace. And those perspectives also shape bias, whether it's implicit or unconscious or explicit or conscious. We do all have biases. So if we think through it, what is explicit bias? These are these biases that are directly expressed, and we are aware of these biases. They operate consciously. They are an expression of a direct result perceived of a threat. This is where group boundaries distinguish themselves from each other, and this is really the origin of discrimination and hate speech. On the other hand, implicit biases, these are those thoughts that are deeply ingrained negative attitudes and feelings that we have about people, and they're typically based on characteristics such as race, ethnicity, age, and appearance. These develop over the course of a lifetime through exposure and direct and indirect messages that we all hear, and we unknowingly inherit this from our parents or our environment. It's learned, it's adapted, it's unconsciously embedded in who we are and how we show up in our environments. And they're expressed indirectly, we're often unaware, and they operate subconsciously. So I'm here to really remind everybody that this is hardwired and we can't wish it away. So the first question I have for the entire audience joining us today is, do you believe that you do or you don't have bias? A, if you believe you have bias, B, if not, and C, if you're unsure. So I would say in the past 3 years, I've been speaking on this topic. We can see that society is evolving. The majority of the time, I'm not seeing a 96% in the actual belief that you have bias. So either we're an incredibly enlightened group, or we've seen so many things change in life, in our world and society, that we're all becoming acutely much more aware of this. So the next question I have is, do you perceive that you have experienced bias of any type? Okay, thank you. So for level setting, it appears that most of us, if not all of us, have perceived bias of some type. So the next question I have is, do you perceive you have experienced bias because of your race or your ethnicity? Okay, so nearly half and half. And I think that this really frames the perspective and the mindset for moving forward. So what are bias motivations? Law enforcement report in 2017 through the FBI really reveals that most bias motivations are based on race and ethnicity, less so on religion, sexual orientation, disability, gender identity, or gender. And I really believe that bias and hate are on a spectrum, where hate is on the far end of that spectrum. What is hate? Hate originates when something is perceived as a threat to our happiness, our success, and our well-being. Hate groups include the KKK and others. And why does this happen? It's because we all have some type of underlying fear. And it's a fear that's leading to a reaction to something that is different than ourselves. And so we start to group off in the in group or the out group. Hate is not just in our history. In the United States, the presence of hate groups has reached record numbers. And as you see in this scattergram of the United States, where this is mostly concentrated. In the time that I finished residency training and started my first job, we can see that the record number of hate groups in the United States has over doubled. In the past several years, you can see a third straight year of increasing rates of hate crimes. And most bias crimes and incidents are centered around race. And the clarion call for all of us is the unfortunate tragedy of the George Floyd incident, really raising awareness throughout our entire country. While this is on one extreme, how bias and perceptions can lead to such an emotionally engaging tragedy with worldwide ripple effect, I would say biases in the workspace are microaggressions and they occur. While there isn't a knee on a neck causing oppression, microaggressions, these daily commonplace verbal or behavioral or environmental indignities do impact. For one person, nurse, can you find me a doctor when she's actually a physician? Another, do you speak English? Another, are there any doctors from America here? And people who experience these microaggressions on a daily basis are harmed. That's why myself and my colleague, Dr. Julie Way, who is another division chief in my specialty, we're not perceived as the boss. Sometimes we're perceived as bossy. These are these reactions when something is different than our own perceptions. Whereas one of our other colleagues, Dr. Cedric, he's perceived as the janitor and not the surgeon. It's because it's a reaction that we perceive something as different than our perceptions of what we are or what we should be. And after years of experiencing this, it's an emotional tax. The emotional tax is that state of being on guard, consciously every day preparing to deal with this potential of bias or discrimination. And I would say from my own personal experience, this can be a contributor to burnout, and it can compromise the well-being of anybody who is experiencing this on guard, this microaggression, and the emotional attacks. All of us have been on an airplane, and many of us have been called to respond to the event of an ask for a physician. 2 years ago, on a Delta flight, you can see this very accomplished African-American physician, Dr. Stanford, was asked, is there a physician on the flight? And she responds, likely having been a recipient of this emotional tax, and the flight attendant continues to ask her, is she really a doctor? Think how she feels. She's here to help, and someone is questioning her credentials. And then she turns around and says, this is something the medical community has embraced as a reality. When you Google a doctor, most of the pictures that you see that come up are that of white men. Again, aiding and engaging the perceptions moving forward. I'd like to say that these biases, they get in the way of creating an integrated and functional work team. Diversity in our environments is essential moving forward. Why? Diverse groups are necessary. They're more innovative. Our diversity allows people at better problem solving of complex problems because we come with different perspectives. And then when we're around diverse environments, we're much more prepared to provide counter alternative viewpoints so everybody grows as a whole. We should also recognize that the world is more complex and that we need diverse perspectives to manage the forever change. And we need this really to navigate moving forward and be open to this change. But the reality about change is most people don't like it. They revolt against it unless they can clearly see the advantage it brings. And for that reason, when good leaders prepare to take action or make changes, they take people through a process to get them to really understand it and be ready for it. And also, you really can't change a society unless you take responsibility for it, unless you see yourself belonging to it, and then you can be responsible for leading that change. You know, humans by nature like certainty, and change brings uncertainty. And that's really a paradox. The world is constantly changing. So change brings uncertainty, uncertainty brings anxiety. And so we back away from change because we don't like that feeling of anxiety. And it is going to take a collective effort to really push people beyond their comfort zone. And in the 21st century, we're really in a new era where change is constant. The world is volatile, it's uncertain, it's complex, it's ambiguous. The competency and the skills that we all learn right now quickly become irrelevant. The potential and that ability to change and learn a new skill is really, really essential for this next generation of leaders and our healthcare workforce to really address the needs of the 21st century. I also want to remind people that the census projection shows in the United States that the minority will be white, and there will be a diversity explosion within the United States. And healthcare isn't immune to these changes. We have mergers and acquisitions. We have changing paradigms for reimbursement. Medicine has become much more competitive. We have pay for performance. And we have all the beauties of this disruption, including telemedicine and being able to reach people quickly and more effectively. We have machine learning and artificial intelligence that is now assimilating data and providing diagnostic algorithms, precision medicine. People in my specialty are operating with robots. So we're in this amazing age of change and disruption. And perhaps one of the greatest changes of disruption for us in the past 10 years is dealing with escalating cost of healthcare. And the business of medicine is rapidly changing. We're going from evolving reimbursement models of fee for service and emphasis on productivity and RVU, perhaps to bundle payment and towards value-based medicine. And in value-based medicine, I'd like to just frame why in the era of value-based medicine, it's really to understand people and their experiences. So patient outcomes in value-based medicine right now, not only do we have to rely on that clinical expertise that we all gain through medical education and experience, and that best clinical evidence to treat patients, we need to start understanding their values and their expectations. And I would argue that it's very difficult to understand a patient's values and their expectations if you don't understand their experience and really look at the lens of life and see your own bias and how that's going to impact our ability to see our patients for who they are. So in that equation of value-based medicine, it's really value, not volume, where in the numerator is quality, patient outcomes and patient experience. And to really improve outcomes and that patient experience is learning our patients' values. And then in cost, how can we more equitably provide access and equitable costs? So I would say, moving forward, there's really an economic reason to recognize our bias and change our perspectives. And undoubtedly, in this past year, COVID-19 has led to perhaps the most unprecedented change that we've seen in medicine in 3 decades. COVID has unroofed inequities in healthcare, racial disparities, and really has brought our own biases to the forefront. And so I would say, how do you look within to navigate change and overcome these biases? Be respectful of all people, cultivate an appreciation for diversity, and really challenge everybody towards problem solving together and being respectful. But internally, it's doing that work for mindset change, challenge your beliefs. And when you do so, you have to have resolve, resilience, and support to maintain that moving forward. And I would say that change is much easier when we understand each other and appreciate their different perspectives. The reality of change is that about 25% of us actively resist change. About 50% of us go with the flow, and 25% of us are champions. So I would just ask for self-reflection and ask yourself where you are personally on this change curve spectrum. For me, I'm way in the upper 5%. And over time, I've had to ask myself, I actually enjoy change, and why is that? And here's where I'd like to integrate some of my own personal story. I would say that our threshold for change and adaptability is influenced by our upbringing, our experience, and the messages that we hear. And as a third generation African-American, this is some of the messaging that I heard early on. My grandfather, a graduate of Mayo Medical College, was the only Black physician for a 100-mile radius in Mississippi. What I learned is that access was always a challenge for his patients. He traveled to his patients. His Black patients suffered from the conditions of their environment and resulted in typhoid and tuberculosis and many other things. His Black patients couldn't afford to pay him. They paid him with non-monetary exchanges such as chickens and eggs and a smile and a hug. His white patients, my grandfather showed up to the Delta of Mississippi in 100-degree weather, always professional. He believed in education and continuous lifelong education, and became a leader and authority in his community so much that the local pharmacist would tell the other doctors what my grandfather prescribed to help someone get well. And eventually white patients got a hold of this, and they would sneak into his office after hours. His community contribution was widespread. Head Start programs to provide opportunities, and he was a community role model. As he practiced, the Flexner Report came out. This led to changes in medical education to improve the quality of medical education, but yet it restricted equitable access for women and people of color to obtain medical education. So to this day, as a result of the Flexner Report, we still have limited access for education to train racially concordant physicians. My grandfather practiced in the era of Jim Crow laws, which led to separation and colored hospitals that were under-resourced. And eventually, during his time, we moved from exclusion to segregated hospitals, but still the social determinants of health impacted outcomes as they continue to do today. While we have moved forward and the legacy of hospital segregation in the United States has evolved, as witnessed by historic events and very important leaders, we still have to remember the origins of distrust and that patient relationship, such as the atrocities of the Tuskegee study and not revealing the story of Henrietta Lacks. By 1964, the Civil Rights Act was passed, which made essentially segregation illegal and discrimination illegal. And this is the time when my own father had just graduated from Mayo Medical College. As you can see, he was a light-skinned African-American physician. He was one of the first to integrate into the Kansas City General Hospital in obstetrics and gynecology, so he himself was a pioneer. That was around the time I was born. You can see he was happy as he graduated medical school, but about a decade later, after facing adversity, discrimination, hate speech, and bias, he was mad. He looked very angry. I had the privilege of attending hospital rounds with my father and visiting his office at a very young age, when he showed up to work looking like this. He would get phone calls to his office saying, "What is Dr. Thompson?" He got so angry about that, he would say, "I'm everything the KKK hates. I'm Black, I'm Jewish, I'm Catholic." At that time, my father, however, never discouraged me from being a physician. I wanted to go into, I loved sports, and I wanted to be Howard Cosell. And my dad just said, "Nope, girls can't do that." But fortunately, he was always supportive of my other dreams. My other early influence is my mother. She taught me how to integrate, when to assimilate, when to advocate, and how to embrace that change I represent. For me, the other shaping life event for me was several years as a competitive figure skater. What did I learn? That I was going to have to work 4 times harder than everybody else to be on that playing field. I would say that my presence has represented change in nearly every environment I've been in. It's required resolve, resilience, evolving mindset from childhood messages, friends, mentors, and sponsors. And I would say that explicit or implicit bias come in all forms, from the environment, from those that are here to train and educate us, from the patients we treat, and from the team members we work with. So what do you do when you experience it? This is my journey and what I've learned. And I'm really honored here to share this with you. For me, it's been an unrealized journey as a pioneer. I was the first Black woman intern in general surgery and resident at the Mayo Clinic, and subsequently became the first Black woman on the staff in surgery. I am the first Black woman to obtain the rank of professor in chief and endowed chair in my specialty. And I was also the first Black president of a major academic society in otolaryngology. All of these experiences are things that my grandfather and my father would have never have seen for myself, and neither would I. So I'm grateful for how far we have come along. And as I've entered into this journey, here's some of the lessons I've learned and helping all of us to evolve. So what do you do when the target of bias is the doctor? I would say bigotry at any level compromises the healthcare environment. It's generally triggered at race, gender, and religion. It's incredibly distressing because we're here to help patients. I think it's important to remember the triggers from the patient. They're in a stressful situation. And sometimes their stress comes out in ways that may be unintended, but are hurtful. So it's important to understand the stresses of the triggers from the patient and ask the anthrocultural beliefs of the individuals and see if there's a legitimate concern. I would say you can't prevent this from occurring, and it's important to educate trained physicians to be prepared to address discriminatory episodes and move forward. So a few vignettes that I learned from, and this is really as an honor to the mentors and sponsors that I have had the privilege of working with. When I was a trainee, 56-year-old woman presented with a parotid mass for 6 months. Her environment, she comes from a farming community in North Dakota. She probably had never seen a Black physician in her entire life. 5 children, and she was widowed. I apologize, I am having some technical difficulty with the program freezing. See, I had lockout on PowerPoint. Let's see if we can get back to where we were. Could someone confirm you're able to see the screen?
Yes, I can see it.
Okay. Okay, let's get us caught up.
Dana, maybe it has something to do with the bank.
Okay. So, from this woman, Thompson, my last name S-O-N, you must be Norwegian. And then she paused, she says, I'm sorry, I didn't really look at you. You must be Indian, like from the Middle East. And then I responded, no, I'm not Indian from the Middle East, but I do have some Native American heritage. And she just couldn't let go of this. And I learned from my father that I was going to have to address this question, but I needed a different answer. For me, I said I'm Black, but I consider myself to be part of the American melting pot. I'm part Black, I'm part Native American, I'm part Eastern European Jew, I'm part Italian, British, etc. And then she goes on to say, oh no, you're not honey. You know, my mentor at that time, as I tell him this story, he goes in, introduces himself, and he says, oh, you met my Norwegian twin. I think the lesson to learn from this is bias, perhaps, probably ignorance from lack of exposure. And every time you're able to add some humor to a difficult situation, you win. Another learning opportunity for me is a 64-year-old came from Virginia with recurrent frontal sinusitis and headaches and multiple sinus surgeries. And she was referred with the diagnosis of a mucocele, saying, I've come to this organization for you to fix me. And then she goes on to say, it's hard enough for me to have a Jewish doctor, and I'm not used to women doctors, let alone that is a Negro. And no offense, I only want you to do the surgery and she's not to touch me. So again, you have to think about the time and the perspective. She's in her 50s. This is 1994. To her, I wasn't Black, I wasn't African-American. Her upbringing was that I was a Negro. Implicit or explicit bias. My mentor, Dr. Jean Kern, encouraged, think about the anthrocultural perspective of the patient. And sometimes you almost have to deal with this by seeing it from the bias or your own implicit bias. So he says, think about this woman. Where did she come from? What came to my mind is a Southern belle. And I just had to see it from that perspective. And it really helps frame things. You know, from moving forward, you also have to look at it from the patient's stressors and find out if there's fear and anxiety. And for this woman, there was a diagnosis of anxiety and depression. But then also ask, is there an organic problem? She had a very large frontal mucocele impinging under her frontal sinus and her frontal lobe, and perhaps leading to how she was articulating with us. The last of these vignettes during residency, a 58-year-old woman with a supraglottic laryngectomy, meaning a majority of her larynx removed after a cancer, hospitalized with compromised what we call supraglottic speech. I'm new to the service and I meet her for the first day, and she looks and she says, I don't want the monkey girl taking care of me. My mentor, sponsor, and friend now, Dr. Larry DeSantos, says to her, I will arrange for you to go to another hospital. As we leave the room, he, in his own way of dealing with the humor with this, dealt with it with his own kind of humor. He says, I should have cut her whole larynx out. Appropriate or not, I think sometimes what I needed at that time was an intolerant attending who made me feel important, knowing that he was going to help me moving forward. Moving forward about 2 decades later, you know, I have some expertise in laryngomalacia. This is a 3-month-old infant girl, comes from a large Midwest metropolitan city with very well-trained otolaryngologists. And, well, you know, affirmative action. And I actually said yes. You know, in a day and age, affirmative action gave me the foot in the door. And then you have to just step back and understand if that is going to be a problem for the family. And so I openly said, I'm more than happy for you to see another one of my colleagues. I needed to make sure that they understood that my other colleagues were women. And I said, I'm more than happy to refer you to other excellent physicians in your community. That itself broke the dialogue. It created a conversation that may have otherwise been uncomfortable. And we established a wonderful relationship. I think the other thing is important for everybody is to leverage your environment and your expertise. Leverage your surroundings, leverage your experience, speak confidently with data and experience as part of really demonstrating that you're there to help the patient. So what are some of the approaches to a discriminatory patient? Cultivate that conversation. Why? What concerns you? If you're in a team, it's important to educate the families about the team structure and that the person that is the subject of the bias is validated, that they are an essential member of the team. And it helps building that dialogue and that trust. I think the other thing is never let one of these events go by without having a conversation with the team and pointing this out. It provides the opportunity for everybody to see it for what it is. And for that person that's on the receiving end, please respect that and honor it and allow them to have some time out to self-reflect and be supportive. Our environment can also pose problems. I would say if you're on the receiving end of such, have the courage from within to reflect and don't be afraid to speak up and find those that will support you. When I was a resident, posted in an operating room was something that was entirely misinterpreted or inappropriate as a racial slur. I personally was offended. At this time, as you can see, if you take the time to read how offensive this was to me as a Black woman, you know, I consulted my father and he said, keep your head down, get trained and move forward. At that point, I had to say, I respected the environment that I was working in and the opportunities that I was given to be educated and that I wanted to make the place better. So after consulting with my chair, I chose to speak up and write a letter to the CEO of the organization and the leaders, effective leaders. What do? You take these matters seriously and remember that a personal acknowledgement can go a long way. And then to this day, I am always appreciative of how Dr. Robert Waller responded to this with a personal note. My program director at the time, it's important, again, as you see people involved in these type of subjects of bias, it's important to support the colleague who feels discriminated against and also remind them that they should not be a victim and that they're supported. And that's exactly what my program director did for me at that time. And as I've moved forward in my career, I've had the opportunity to mentor others. And again, here's a teaching example. This is a PGY5, chief resident in a surgical discipline. An emergency case comes in. It's an orthopedic case. And the expectation from the attending surgeon is I'm on my way. Please have the operating room set up to do the specific case. The PGY5 notifies the charge nurse and asks for the specific tray for the equipment. Charge nurse responds, not by using her first name, but calls her by her first name, but not her official title, but her first name. Miranda, Dr. X doesn't use that tray, and I'm not getting that tray until I see Dr. X. This woman, being subjected to this time and time again, has learned to compensate. So she says, wait, she'll get the tray for him, the youngest member of the team. So she says, Justin, can you go talk to the charge nurse and have the emergency case set up? Sure, Dr. Chambers, right away. Anything else I can get? So obviously, what's the difference here? In her mind, she's been working here for 5 years and it's the same thing over and over again. In his mind, what goes on in his mind? Is he artificially empowered to think, I have this kind of response from the charge nurse? Or does he self-reflect and ask, wow, this has really been a struggle for my chief resident for years. Nonetheless, in this case, what happened was a distaste by the resident for the organization in the hospital, and she actually chose not to pursue that subspecialty because she labeled her experience in that subspecialty based on this. It creates a negative reputation for the next generation, such as hospital X is racist or program X hates women. Doctor attending did nothing about it. Again, artificial empowerment of those that might be less knowledgeable or experienced members of the team of what the patient actually needs. And I would argue that this can be a safety issue. And again, it's a missed opportunity to educate members of the team who may be completely unaware. So I'm here to say that everyone perceives bias. And this is a very nice study out of Georgetown University and the Department of Surgery. And you will see that men and women equally perceive bias from our patients, and that women perceive bias more from the nursing staff, administrative staff, and the clerical staff, where men perceive bias more from people who are more on the professional side, attending physicians, other residents, and interns, or other school professors. Nonetheless, implicit and explicit bias in the workspace, it will happen. We're human, you can't avoid it. It's important to have strategies to de-escalate, add humor, add data. But most importantly, I think encourage talking about your experience and assisting on an institutional awareness and training, and remember to support a colleague when you see it happening. And I would say the strategies for those experiencing the emotional tax of this: focus on self-regulation, preserve your energy. Not every action or word deserves or requires a reaction, and learn how to speak up in effective ways with the intention to educate and lead mindset change. And when you receive these, keep in mind that stereotypes and biases are unfortunate, but they don't have to stop you from achieving your potential. Manage the narrative in your head, find healthy outlets, find a team, have community, have conversations, and bring others along in understanding what you're experiencing. So in summary, seek out and build your team. And for mine, you can see my team has been diverse. So moving forward, how do we create a sustainable change for the future? You have to close this diversity gap. You have to know where you start and have well-defined goals. Acknowledge those gaps, strive to fill them, make intentional change, and then measure it. Your organizational mission and vision statement must include diversity. You have to know where we start. In the United States, currently, only 9.6% of the faculty at most major medical institutions are that of an underrepresented minority. We don't match the demographics of the United States. and 39% are women. You have to work really hard to grow, maintain the diversity in your leadership structure, your governance, your faculty, and on your boards. That's where the perspective and the mindset change has a voice. Keep in mind, this pipeline is leaky. This is from my own specialty in otolaryngology, head and neck surgery. So if we compare the US Census and population of 13% African-American and 18% Hispanic, as you go through medical school, application to residency, otolaryngology residents, and then within the academic ranks, you'll see that this pipeline is incredibly leaky. That's where allyship is incredibly important. This is what I call my wall of 8 white men. These are all the people who have mentored and sponsored me in incredibly meaningful ways. I would advocate to acknowledge within yourself that different is okay, and it represents an opportunity for you to learn as you mentor, sponsor, and coach. Try your best to be colorblind and genderblind and see people for their potential and see them beyond your own bias. And for those of us that may not feel like we have role models, mentors that look like us, keep in mind that it will take that courage to build these relationships with those that may not look like you, and acknowledge your own biases about those who can mentor you. We also have to acknowledge where we are in our training programs. If we look at my father's specialty in obstetrics and gynecology, they're doing the best in terms of equity and diversity. If I look at my own specialty in otolaryngology, we continue to be at the bottom. Diversity in all specialties is important. Why? Minority patients are more likely to seek care and trust a racially concordant physician. Minority physicians are more likely to return to their communities and serve vulnerable populations. And diverse physicians will ask relevant questions about how to advance medicine scientifically through research, and really ask about questions to address race and other social determinants of health and how they impact our outcomes. You have to have a plan to address diversity. Here at Northwestern, over a decade and a half, because of our efforts, we have increased our underrepresented minorities within our organization from 2.2% to 14%. You have to create a welcoming environment and make intentional change on a measured and productive way. Implicit bias training, create safe spaces for people to speak up, cultural competency training, and holding people accountable. I ask that we all strive to create a healthcare team that really reflects the demographics of our nation. If we look at the ethnicity and demographics of the United States compared to the physician workforce, we still have a long way to go. Keep in mind and remember the pipeline programs work and diversity inclusion efforts matter. And bias and sustainability in the 21st century healthcare with escalating costs, we are all responsible for delivering high quality care and fiscally responsible care, and addressing that iron triangle of medicine, where we are bridged and challenged by escalating costs, managing our access, and providing high quality. And keep in mind, when one area of the triangle expands, the others are compromised. So how do we balance this? In the United States, the reality is that we spend over $10,000 and almost 18% of our GDP in healthcare, and we still remain at the bottom quartile amongst developed countries. We underperform in our outcomes, we underperform in access, we underperform in spending or in our outcomes despite our spending. And for what we spend, people in the United States are not living any longer. And I'd like to close this data by saying we underperform in equity, which I believe is one of the drivers of why we are where we are. And why is that? Is that those populations that are going to be at greatest risk for poor outcomes are the ones that we have bias towards, either race, ethnicity, sex, age, gender, where do you live? And these are the patient populations that have challenges to access. And our biases get in the way of acknowledging how the social determinants of health impact our outcome. If you think about the pie of outcomes, only 10% of what we do in clinical care really changes this. Genes and biology, the things that we do to influence outcomes, are only 10%. and health and behavior. But really, half of that pie is all determined by where someone lives and their socioeconomic factors. So we must recognize them and participate in meaningful advocacy for change. So creating that balance and parity and equity in the context of that iron triangle of medicine, of quality, access, and costs, and achieving that ideal state, really balancing equity and parity, where do we go? We have to strengthen our connections to the community and go to the community, much like my grandfather, and participating in care and striving to help. We really have to be active in implementing policies related to healthcare and understanding how to expand the understanding of what health means besides coming to us as physicians. We also have to invest further in social services. If we look at ourselves, the United States, we spend much more on healthcare expenditures and less in social service expenditures than other developed nations. If we perhaps spent more on social service expenditures that address social determinants of health, perhaps our outcomes would be better. We must actively look at how do we integrate social determinants of health into daily practice by asking about food, transportation, housing, and literacy. And then if you see a problem in your community, we have to actively address it. Here in my own practice, we saw incredible disparities between children with recurrent otitis media and their ability to see a physician. So what did we do? Open access for all and streamline our access care delivery model, where a patient can get screened in the community for recurrent acute otitis media, show up in our office, and have their tubes placed on the same day. So we have to rethink about care delivery and innovate and really leverage innovation and entrepreneurialism to help with moving forward. And then to take us back to that value-based medicine equation, keep in mind quality over cost. And if we are not addressing quality and outcomes by addressing social determinants of health, it doesn't move us forward. So I would really like to say and advocate that we have a financial sustainability and an ethical reason to recognize how our biases get in the way of safe and excellent patient care and change our perspectives. So some self-reflection. Our experience and our views of people who we see are different are going to create bias in ourselves. So if you haven't taken the implicit bias test, I would encourage you to do so. We have to recognize that we are all products of our environment, and incoming medical students, based on their ideology of their upbringing, liberal, conservative, or moderate, we know from this study that at year 4, those who came into medical education with conservative ideology had greater implicit bias against Blacks, gays, and individuals, and lower levels of patient-centered attitudes. So we just have to recognize this and really help mind shift change as we educate the future generation. We also have to admit that race, ethnicity, and bias affect patient treatment. In my own specialty, 1 out of 5 of us admit that race and ethnicity change how we view patient care. Medicine is a team sport, and I would say that a difference of perspectives is considered essential to patient care. And remember that members of your team are going to show up every day with the burden of the emotional tax from bias and may choose not to speak up when they should. That emotional tax of being on guard really faces challenges to physicians' well-being, leads to higher rates of anxiety and depression, and those that are on guard are more likely to leave their jobs and their employers. Important to recognize that as we work in teams, this emotional tax that several of us experience on a regular basis. And I would say strive to eliminate bias, to understand your diverse team, and teamwork is protective against burnout, and create that joy in practice for what we're here to do, and that is restore health, wellness, and normalcy to the best of our possibility. Think about integrating a paradigm for education and advocacy into daily practice. It includes structural competency, creating trust building with our patients and our environment, and cultural humility, active self-reflection, and really re-mindset change, and providing experiential learning as that platform for growth and development. And as you focus within and moving forward, think through, you're within your own mindset and then within the profession of medicine and our surroundings. And to really understand the impact of bias, it requires acknowledgement and a mindset reset. And we risk being insular and segregated in our mindset, in how we practice, how we care for patients, how we advance science, and how we educate the next generation, and how we work in teams. And so mindset expansion is essential. And like any other living organism, if you don't change, you don't grow. And as you change, you inspire others and bring a new state of relevance to consciousness for everyone. And in this day and age where we're faced with the changes of COVID and social injustice, I would say let the injustices of healthcare and COVID inspire you all individually to reflect within and ask how you can drive change. And of all the inequities that exist, the injustice in healthcare is the most shocking and the most inhumane. And perhaps this is the greatest time in our lifetime to reset and move forward. And as we're all scientists, I'd like to close with saying that everything is energy and that is all there is to it. Matching Einstein's word, match the frequency of the reality you want, and you can't help but receiving that reality. It can be no other way. That's not philosophy, it's the laws of physics. So encouraging, give the compassion you want to receive, and you will receive that compassion that you get and you give in the art of medicine that we are all educated and empowered to do. So I'd like to thank you for being open to listening and learning and growing. And remembering that bias is a part of our reality. Thank you.
Thank you very much, Dana. That was very inspiring. And there had been a couple of questions about availability of the material you presented, and for all of the attendees, that will be available probably next week or thereabouts on the website, the APHC website. I see a couple of comments coming up in the chat, and let me see if I can direct those to you. A lot of thank yous and praise, wonderful presentation. I don't see any particular, oh, here we go. What is your response? Oh my goodness. There's a politically charged question that asks about response to the president's executive order limiting diversity. If you care to take that on, Dana?
Absolutely. I think that's our reality, to respect diverse opinions and perspectives. And it's almost a contradictory statement in the sense that, you know, the reality is if we don't recognize the historical legacy in the United States, why we have the issue, then we're not American. To try and not provide my own political perspective on this is we just have to look at what America was founded on and the economics of the time. And that was the impact of slavery. And that type of marginalization has led us to where we are now. And we have to recognize that, and we have to reconcile that individually and as a society. And so I think limiting perspectives on diversity is un-American. And it actually doesn't help the economy, and it doesn't help humanity. So I think I'll limit it to that, just as framing it as the historical evolution of where we are as a nation.
Thank you. That was very diplomatically stated. And I think that most of us couldn't agree more and are in many instances ashamed of where we stand, both as a nation, but also amongst other nations around the world. And I appreciate the data you shared in that regard. professionalism certainly calls for this awareness, and to be a professional in a service-oriented profession such as the healthcare professions that all of us represent just can't stand beside the type of discrimination, explicit bias, and refusal to recognize our history. So thank you for sharing so much today with earnest, honest, lived perspectives. Thank you so much, Dr. Thompson.
Yeah. Thank you. Really, I'm inspired by the mission of the organization, and I'd like to thank Ellen Friedman for encouraging me to get to know you better, and look forward to joining.